everybody, it's Elizabeth. Welcome back. This is going to cover a patient concept map on hyperthyroidism. If you didn't watch the hypothyroidism section already, please go back and do that first. Or if you're not interested in that and you're only watching hyperthyroidism, just make sure that you have watched that first little part of the hypothyroidism video that talks about the way that the thyroid is controlled by the anterior pituitary and the negative feedback loop and where the thyroid is located in your body, etc. All right, so let's dive in here to hyperthyroidism. Okay, and I've got my gazelle here to represent hyperthyroidism. He's really hyper and really fast because that's what we see in patients that have hyperthyroidism. Okay, so we'll start out in the typical place of patho here. So this is an excessive secretion of the thyroid hormone from the thyroid gland, which results in an increased metabolism of the entire body, okay? So the way that things are broken down and food is processed in the body, all of that, everything in the whole body basically is affected by the thyroid, so your metabolism and everything is increased. And this one is most commonly caused by an autoimmune disease called Graves' disease. So most commonly, if we have hyperthyroidism, it results from Graves' disease, an autoimmune disease that attacks the thyroid. It could also be caused by multinodular goiter. And this is, we talked about in the last video, we'll go over again, a goiter. You've got your thyroid here in your neck, and the goiter is when you get this fullness, which is an enlargement of the thyroid gland. So you have like this fullness in your neck. And so the thyroid sometimes develops nodules, so these little growths upon the thyroid. And some of these growths can actually produce thyroid hormone. So this multinodular goiter, which is a reason for hyperthyroidism, is all these little nodules that develop on the thyroid that then develop their own hormone in addition to the hormone that your thyroid is already creating. So you get too much thyroid hormone, too much TSH and too much T4. Okay. And then it could also be caused by excessive thyroid hormone replacement. Okay. And so we talked about that in the hypothyroidism section as well, that we are taking levothyroxine or thyroid hormone replacement medication to regulate our thyroid. And if we get too much of that, it can cause symptoms of hyperthyroidism. Okay, not good. All right, so we'll go over here to assessment, and this is going to be the symptoms that our patient is going to develop based on, or the things we might see based on their hyperthyroid. So they're hyperthyroid, their thyroid is too high, okay? Everything's increased, okay? So we're going to have weight loss because our metabolism is just going. We might be eating excessive amounts, but our metabolism is just really zooming through all of that, and so we have weight loss. These patients often are going to have tachycardia, so their heart rate is going to be too high, and they can also develop abnormal cardiac rhythms associated with the tachycardia that they have, so that can really be a big problem. They can develop hypertension, so their blood pressure can become really high. Heat intolerance, so they just are extremely hot all the time, no matter what they do. They're just hot, sweating, that type of thing. They may have a low-grade fever, so their body temperature is kind of running at a little bit higher rate than what it should be, okay? And then in the same respect as their gut, it's moving too fast as well, so they can develop diarrhea. They're going to be hungry. They're going to just be like starving, like I keep eating everything in sight and I just keep losing weight. Their hair is going to be thin. They're going to have increased libido, so they're going to have an increased sex drive. They may display manic behavior. And if you don't know what that is just whenever you have excessive behavior. So like you are running around, you're not sleeping, you are, a lot of the features of mania in reality are they're like become obsessed with things, they're spending all kinds of money, they're cleaning the house from top to bottom, they're just doing everything at extreme fast pace. They're going to have decreased attention, so they just can't really focus on anything, probably because their mind is racing. And then goiter, we talked about that. They can have the big kind of fullness in their neck around the area of their thyroid. They oftentimes will have amenorrhea, so they will have no period. Okay, they have no period, no menstrual cycle. They may have retraction of their eyelids, so these, eyelids kind of get pulled back. They may have insomnia, they're not sleeping, they're just doing all kinds of different things. Tremors, so they kind of are like shaking, they shake. They may develop palpitations, which is just where they feel like their heart is racing, and their heart probably is actually racing, but they feel like their heart is going to beat out of their chest. Exophthalmos, which is whenever their eyes kind of protrude. So they kind of have protrusion of their eyes, and it's a really classic look, and most textbooks are going to have this same poor lady who keeps getting picked on because she offered her picture, and it's just, her eyes are just really protruding, but it's a very good example of what exophthalmos looks like, and it's kind of one of those classic things that we see in patients who have hyperthyroidism. And then they're going to have muscle wasting, so their muscles are just going to be kind of like wasting away. They'll have mood swings, and I already said they may develop diaphoresis. So here we have an example of some of these things, if I can find it. Okay, so we've got this tremor, diaphoretic. This guy, he looks like he's got some exophthalmos, like his eyes are kind of like popping out of his head. Okay, and we do have some interventions that we need to do for that because that is not good. And then, cardiac issues. Okay, so that's going to be for assessments. And then tests, our T3 and T4 are going to be high. So I already discussed that those levels are produced by the thyroid. So the thyroid itself is hyperthyroid, so it is producing excessive amounts of T3 and T4. And then their TSH, their thyroid stimulating hormone, is going to be low, because we don't need very much thyroid stimulating hormone if our thyroid is already producing large amounts of the hormone. Okay, so those are the blood tests the patient's going to get. They may have a thyroid scan, which looks at the position, size, and function of the thyroid, and it really kind of looks at uptake of iodine. It's very complicated. I would just know that, there's a thyroid scan, and then thyroid ultrasound, which, we use the ultrasound machine just like when we're looking at a baby, to look for the size, so we can see how big is it, does it have a specific mass on it, are there nodules? We had talked about before that sometimes this multinodular goiter may be the cause of hyperthyroidism. So if we do an ultrasound on that, we can see, are there lots of nodules? Is that the underlying issue here? And then the patient may require an EKG because they may have some abnormal cardiac rhythms based on just having this increased metabolism. So some of the rhythms, which you may not have learned about all of these yet, but these are just things to keep in mind. This patient may have what's called SVT, which is supraventricular tachycardia, which is just when the bottom part of the heart really gets to racing. And then atrial fibrillation, which is a problem with the atria, the top part of the heart, but it's also a rapid rhythm. And then PVCs, where the bottom part of the heart kind of contracts prematurely. And so these are called premature ventricular contractions. And I don't think, if we haven't covered cardiac yet, we don't need to memorize that just yet, but those are just things to kind of keep in mind. Okay, PATI, we need to go down here to interventions, and oh my gosh, there are so many things that we need to think about for these patients as far as interventions, because they are not in good shape. So one of the things is to decrease stimulation. So turn off my lights. Don't let me have 50 visitors. If I'm in the hospital with a hyperthyroidism problem, we just really need to try to decrease stimulation. And so that might also include not having access to tablets and phones and all the things that just keep our minds racing 100 miles a minute. And then promote comfort, make sure their bed is comfortable, that they're, in the best state that they can be to kind of just be relaxed and be calm. And then we need to monitor their apical pulse, from here to just kind of really make sure everything is working like it should be and we're not hearing abnormal rhythms, rates, things like that. Monitor their blood pressure because like we said, they could have high blood pressure. And then we need to monitor them for chest pain because we don't want their underlying problem to lead to actual cardiac damage. And if they have chest pain, that really needs to be addressed quickly. And then we need to immediately report increases in temperature over 1 degree, okay? If the increased temperature develops, we really need to monitor the cardiac status, okay? So the temperature is kind of one of the first things that really starts to elevate in patients with hyperthyroidism, and we're going to talk about the extremes in a minute, and that is one of the things that we monitor closely, is temperature. And then I already said we should limit their visitors. We don't want any extra stimulation. Postpone non-essential care. Gosh, I don't know if you've ever been in the hospital, but when I had my children, there was somebody in there every 5 minutes for something or another. So if we can just kind of limit all the people that are coming in and out of the room. So a patient who has hyperthyroidism and is like really not doing well with that, we may not want to have students in and out of there and, that type of thing. And then provide cold water because remember they're feeling really hot, so it's going to feel nice for them to have cold water. And then if they become diaphoretic and their sheets are getting kind of damp from that, we should offer to change their sheets. We may want to give them some artificial tears or see if we can get an order for artificial tears because when their eyelids are retracted and their eyes themselves are kind of bulging outward, their eyes get really dry because they can't actually close their eyes all the way sometimes. Or even if they are, they're just not being moisturized like they normally are. So artificial tears, and then also elevating the head of the bed can just keep them from having additional swelling in their face, so elevating the head of the bed and doing artificial tears, and then suggesting frequent rest periods. So, if they are doing things, they just really need to rest. And then we have anti-thyroid hormone. So there's a couple of different medications that they use for this, and we're going to talk more about that in a moment. And then radio ablation, which is a procedure that's done on the thyroid to try to decrease its activity. Iodine preparations, so sometimes they use iodine to kind of regulate the thyroid. And then radioactive iodine, we'll talk more about that as well. Thyroidectomy, so they may actually have to go in and remove the thyroid. And so then these people are taking thyroid replacement when their initial issue was too much thyroid. And then beta blockers. So beta blockers, how they work is they block the sympathetic nervous system, okay? And the sympathetic nervous system is that thing that gets activated when a bear is chasing you, okay? So all the things kind of like get really pumped up. Your heart rate goes up, your blood pressure goes up, you start shaking, you're just like really panicky because this bear is chasing you, and that's your sympathetic nervous system, helping you to get away from the bear. But we use beta blockers to block that from happening, so that helps to control tremors. It lowers the heart rate, it lowers the blood pressure. So it is something that we use to therapeutically treat the patient's symptoms, but it doesn't actually correct the underlying problem, which is the thyroid. That needs to be corrected. But the thyroid medications can kind of take a while to actually have effect. So in the meantime, we give some beta blockers to just kind of slow things down. Okay, so we'll talk about this anti-thyroid hormone. So just like when we talked about the levothyroxine, the medication we use to treat hypothyroidism. We had to watch for symptoms of hypo and hyperthyroidism. Same thing here. If we're giving a patient anti-thyroid hormone, we want to make sure that they're not getting symptoms of hypothyroidism because they're getting too much anti-thyroid hormone. Okay, so it's got to be regulated super, it's like just super got to be right in the perfect range. Okay, and then we're going to monitor these patients for signs and symptoms of infection because the anti-thyroid hormone is an immune suppressor. Okay, so that medication suppresses the immune system, and so the patient, we need to make sure they're not developing an infection. So the two most common ones are methimazole. Methimazole, I would say, is definitely used the most. Okay, so methimazole, but we want to keep in mind that that is a teratogen, and as we've discussed in the past, teratogens cause fetal abnormalities. So if somebody is pregnant, we do not want them to be taking methimazole. Okay, and then we have propylthiouracil, which is another one. It is not as commonly used, okay, but it is an anti-thyroid hormone. It can cause liver toxicity. So just important anytime you're learning about medications and somebody tells you, oh, this one causes X, just keep in mind, what would the symptoms of that be? So, on an exam, you might get a question like, the patient is has hyperthyroidism and is taking, this specific medication, and they develop jaundice and, things like that, symptoms of liver toxicity. And then you're asked what action you should take based on that information. Holding the medication or notifying the provider might be a good idea. I think that will help you out in, pharmacology class. Just always try to keep in mind that you should try to know what the toxicities look like, okay? And I'm not saying that's going to be on your hyperthyroidism exam or anything like that. I'm just saying that is something just always keep in mind. Radio ablation, so they go in there and ablate portions of the thyroid, which is just kind of like burning little areas, so maybe they will stop producing some of this abnormal amount of the hormone. Iodine preparation, so they give these doses of iodine which can decrease blood flow to the thyroid gland and kind of stop it from producing so much thyroid hormone. Radioactive iodine, so this is usually given orally, and it may take 6 to 8 weeks to relieve symptoms. So during that 6 to 8 weeks, if they're getting radioactive iodine, they're still going to have to take their methimazole, or their other anti-thyroid medication, because it's not going to take effect right away, okay? And there is an unsealed source, so if it is an unsealed source of radioactive iodine, they have to take these additional precautions because they don't want their family to be exposed to radioactive iodine. And it is passed in patients from bodily fluids and stool. So this may include anything to do with like using the restroom. They may have specific recommendations on what they need to do to prevent this from being exposing family members or other people, blowing their nose, laundry. There's all kinds of specifics on that, which we're not going to go into, but that is something to keep in mind. And then if their entire thyroid gland is destroyed with radioactive iodine, then they're going to need to take lifelong thyroid hormone replacement. So I did radioactive iodine because I had hyperthyroidism. My thyroid was just destroyed from that. Now I don't produce any thyroid hormone. Now I'm going to have to take levothyroxine or thyroid hormone to try to help that. And then thyroidectomy. So instead of doing radioactive iodine, or if radioactive iodine doesn't work, they might just go straight for doing a thyroidectomy where they're just going to take out my thyroid. And boy, that causes some big problems because as we're going to learn about in the future in other sections, the thyroid, also behind the thyroid on the posterior portion of the thyroid, live the parathyroid hormones, okay? So not only now are we taking out our thyroid, and we're going to have to take thyroid replacement for that, we also have taken out our parathyroids. And now what are we going to do about that? We'll talk about that in the future. But thyroidectomy. So this is a very serious surgery. Your neck contains a lot of extremely important structures, right? You've got huge arteries in your neck that, if I accidentally nicked an artery in my neck, I might bleed to death. There are your voice box is there, your airway is there. So this is a very serious surgery, should be taken very seriously. So first of all, for pre-op, we want to make sure this patient is completely stable. This patient is not having cardiac compromise because of their hyperthyroidism. So we've got to get them under control medically before they are going to be able to have surgery. And then once they have surgery, for the post-op care for the nurse, we need to monitor for complications. Okay, so signs of bleeding in the neck. And if our patient is laying in bed, that might present on the back side of their neck. So we're going to actually need to really keep a close eye on their neck, watching for any signs of bleeding. And if they're having underlying bleeding, they may just have like a lot of swelling in the neck that's new or that's kind of happening rapidly. That needs to be reported immediately. They're going to need to have their vital signs monitored every 15 minutes, because if they are losing blood from like a giant artery in their neck or even a big vein in their neck, their blood pressure is going to plummet, right? So, and their heart rate's going to go up. So we just got to really closely monitor these vital signs and then treat pain. I'm sure it's extremely painful to have that gland removed in your neck. So we got to treat them with pain, and then use pillows to support the head. They're typically sitting upright with those pillows, and that's going to help decrease swelling, keep the airway as open as possible, that type of thing. So we're monitoring for hemorrhage. I talked about that. If we are having any hemorrhaging or swelling that's extreme, we may develop respiratory distress. Okay, and so we're going to need to be watching for laryngeal stridor, which is going to indicate a respiratory obstruction. And if you don't know what stridor is, it's kind of like this sound that is made on inspiration. So if you ever had a kid with croup, they have stridor, but it's kind of like a, So we're watching for something like that in the patient with post-op for hyperthyroidism. We should have oxygen and suction equipment readily available in case we do run into trouble. We can really just not have to mess with setting up a bunch of stuff. And then we're monitoring for symptoms of hypocalcemia, which, as I already alluded to, the parathyroid gland is located on the back side of the thyroid, and that little tiny structure regulates calcium. So we're monitoring for symptoms of hypocalcemia. And that usually, if you're given a test question on that, it's going to be something about like tingling around the mouth. It's a really common one. But in the parathyroid lectures, we will talk more about that. And then laryngeal nerve damage may occur. So the laryngeal, your larynx, think about laryngitis, laryngeal, your voice, right? So the patient may have damage to that nerve. It's usually temporary, but it can cause voice changes. And so that's just something to keep in mind. And then, as I already talked about, the beta blocker treatment, we do use that, and it treats the symptoms. It doesn't treat the underlying cause of the thyroid problem. So it's really just used to kind of help the patient kind of with all of the hyper kind of symptoms that come along with hyperthyroidism. And a really popular example that they use specifically for hyperthyroidism patients is propranolol. And if you remember, beta blockers end in LOL. And it's not because beta blockers are funny, but that is the case there. Okay, so then we're going to move over here to extreme. Worst case scenario for our patient with hyperthyroidism is thyroid storm. Okay, so this could be compared to hypothyroidism, has myxedema coma. Hyperthyroidism has thyroid storm. Okay, and so It occurs in patients who have uncontrolled hyperthyroidism, and it can be fatal if it is not treated. Okay, it's a very serious complication. And they develop a fever, tachycardia, systolic hypertension, and they are anxious. And this can progress to seizure, coma, and death. All right, so this really could be very serious. And triggers may include pregnancy. So they already kind of have this vulnerable state in their hyperthyroid. It could trigger them into thyroid storm. And then trauma, any type of trauma could trigger that. Infection could trigger that. And then vigorous palpation of the thyroid. So here's a picture of somebody palpating the thyroid. If you get too aggressive there, you may cause a lot of thyroid hormone to be released and cause thyroid storm. So basically, I think nursing students are really recommended never to touch a goiter in general. And then it is an emergency, so this can be an emergency, and we need to maintain their airway and ventilation. They may be getting IV iodine solution. They may be getting IV steroids. Need to very closely monitor their vital signs. Even 1 degree increase in body temperature is a sign that things are going south, and that needs to really be taken care of quickly and start assessing that cardiac status. And then a cooling blanket. So there are these things called bear huggers, and they hook up to this machine, and you can adjust the temperature, and they can really cool down the patient, especially if they are at a dangerously high temperature. We would want to use something like that. Okay. PATIEN. We are to nursing diagnoses. Anxiety. So these patients a lot of times are super anxious. And then imbalanced nutrition, less than body requirements. So they may be eating a ton, but their metabolism is going so fast that they just can't keep up. Just can't keep up. So this is going to bring us over here to T, teaching. They need to know the symptoms of hypothyroidism. So if they're getting too much thyroid hormone, they may develop the symptoms of hypothyroidism, so they need to be watching for that. They should avoid caffeine. We don't need anything else that's going to hype these people up. Manage stress. If they're, really stressed, that may already affect blood pressure and things like that. So, we don't need that on top of this. They need to take the medication at the same time every single day. Okay? And it can take time to work. It can take weeks to work. Okay? And then call the healthcare provider if they develop a fever. Because we said changes in temperature can be, a big deal in these patients. So they need to let their healthcare provider know. Plus, we had also talked about how the antithyroid medications are immune suppressing. So if they get a fever, we may need to be investigating that pretty aggressively. So a lot going on with hyperthyroidism, but I hope everybody took something from that they will remember. Thank you.